is a senior data scientist at the Provincial Health Data Centre of the Western Cape in South Africa. She has a background in clinical epidemiology, perinatal mortality, and injury mortality surveillance. And Mariette today is going to talk to us about consolidated person-level health data, improving tuberculosis surveillance and patient care. Thanks very much, Mariette. I'll hand it over to you now to share your screen.
Thank you. Just to confirm that you can see my screen and hear me.
Yes,
Hannah.
Loud and clear.
Great. Thanks, Anna, and thank you for the introduction. Hello, everybody, and thank you also to the organizers for the opportunity to present here today. Ooh. So when discussing tuberculosis in the Western Cape, let me just give you a quick overview of the public healthcare system in the province, which serves about 75% of the population, currently more than 5 million active patients. It is a high burden setting with HIV and TB leading, but chronic diseases and injuries are not far behind. Healthcare is provided on 3 levels, but patients are mostly seen at primary care and community clinics. Most of the visit information is captured in the hospital management system, and the true primary care information systems are run by the province and the city of Cape Town. They all share a unique health identifier, which is quite unique in our province and has been in use for more than 30 years. Then there are the multiple other routine information systems, all separate for laboratory tests, acute and chronic dispensing, and disease information systems for HIV and TB. Data are captured by clerks and are mostly reliant on a sufficient paper-based system. Just a bit more about the high TB burden in our province. Just in our province alone, there are on average 55,000 cases per year, which is more than Australia, Canada, the UK and the US put together. And that relates to an incidence roughly 100-fold higher than most countries represented here. TB and HIV are still the highest ranked in terms of years of life lost, although intentional injuries in especially younger men are rising. So it's then easy to understand the information challenges such disparate systems can lead to in providing TB care. More than half of our patients move around between facilities. Data is captured in different systems, and for example, information on comorbidities are not always readily available. Another problem is that even with unique identifiers, clerks may often duplicate folder numbers with different personal information, and it's then challenging to link that information together. There can be also insufficient data management expertise in healthcare workers and a reluctance to use new technologies. We have seen, especially over the COVID period, that people really love their spreadsheets, which are easy to email to other healthcare providers and can compromise sensitive patient information. And lastly, most hospitals are not TB reporting sites, so if a patient is not followed up at a clinic, the case may never make it into the TB information system. But we have been fortunate in the Western Cape to have a data center that daily integrates patient-level health data from all the systems I mentioned, centered around the unique health identifier or folder number. There are currently data from over 30 different sources for over 14 million patients. Data are added daily, cleaned, linked, deduplicated, mapped to concepts, and stored securely. The linked data can then be used to infer health conditions and care cascades, mapping an individual's path through the health system over time. Tuberculosis is just one such condition. So more information about the system is available in another talk. If you want to check it out, it's available on the system and it's by Professor Andrew Ball. So to infer a diagnosis of any condition, essentially backwards from electronic data, can be quite challenging because tests and treatments can span across different health conditions and source data can often be incorrect. But by triangulating many different sources and classifying data points accordingly, we have developed an algorithm that can reliably identify cases. Each case, though, has an assigned confidence level, which of course increase with more data points. So here's just an example of all the different data that we can patch together and create a case of TB. And after inferring a diagnosis, we can then generate a line list of all TB-related visit and treatment information for an individual for each time they are newly diagnosed with TB, which can be multiple times across their lives in our high-burden setting. The line lists are in continuous development with extensive consultation with clinicians and clinical managers in order to produce a set of information that will be useful and actionable where necessary. So developing these information-rich cascades can be very rewarding for us analysts. It needs to be presented back to healthcare workers in accessible formats. So the tools we have developed to this aim are currently available on two platforms, the Cascade line list on a SQL Server reporting platform and a bespoke software called the Single Patient Viewer. The Single Patient Viewer presents linked information from all available sources for a particular individual, essentially a consolidated patient record with clinical details, counters, latest patient contact details for follow-up purposes. SPV also provides the ability to contact patients via SMS and phone calls and can also add follow-up notes for a patient. A relatively new development is the ability to make referrals to community health workers using an integrated mHealth tool called Catch and Match. So the same cascade line list that were previously presented on patient level can also be presented in aggregate format for reporting purposes, and a vast number of indicators can be calculated to satisfy reporting needs as they arise. These can be generated on facility level or district or sub-district or province level as required. So in summary, because of the high burden setting, efforts are largely focused on catching missed opportunities for better patient management. Our consolidated data environment can and indeed has greatly improved on individual disease registers by deduplicating and linking patients across the platform, by identifying additional cases not previously reported in those systems using our disease algorithms, and by presenting data in actionable format to close treatment gaps for clinicians. Also by creating opportunities for tracing and referral via electronic platforms and linking to mHealth applications. But that said, the work is not done and there's always room for improvement. So we have learned a lot from rapid development of a number of tools during the coronavirus response in the province. The public-facing coronavirus dashboard has now made it possible to highlight other health conditions to the public. And as you can see here, TB identification and diagnosis has decreased quite a bit during this period, highlighting the need for TB screening and treatment. Also, another development that can borrow from the coronavirus response is our interactive case listing, which we can now repurpose for TB into a TB treatment action list to identify individuals who require active monitoring and follow-up. So thank you again for the opportunity to present our work, and I would like to acknowledge my colleagues at the data center and stakeholders who support specifically the TB work. And I've also added some additional resources for those who are interested. and thank you.